Dear friends, thank you for being there. And once again, I would like to apologize because of my terrible English. This is why I recorded subtitles that you can put on if you don't understand me. Let's start in this chapter the surgical gestures and first of all the placement of the trocars. Thanks to the operative slit lamp, in more than 99% of cases, I only placed 2 trocars. One between 10:30 and 11 o'clock for my intraocular work, which is a normal position for a right-handed person. The other at noon for infusion. As in all my other indications of vitrectomy, less than 45 degrees from the previous trocar, which is more unusual, but for the following reasons. First, I want to avoid the lower quadrants. I never understood why most operators place their infusion in lower temporal. Certainly the pars plana is there more posterior than in the inferonasal quadrant, but much less so than in the 2 upper quadrants. So there is less risk in placing the infusion at the top. In addition, vitreoretinal lacerations in the sclerotomies, which can cause postoperative tearing, are easier to manage when they are located at the top than at the bottom for both treatment and tamponade. Finally, placing the infusion less than 45 degrees from the other sclerotomy can reduce the risk of lens touch if you decide to perform a peripheral vitrectomy. Let me explain. If your infusion is more than 60 degrees from your probe entrance, you will have trouble in a phakic subject to remove the vitreous around the infusion because the scleral depression behind the infusion will push it against the lens. If your infusion is less than 45 degrees from your probe entrance, you will be able to approach it by passing tangentially to the crystalline equator without making a scleral depression. However, there are cases where the position of the trocar has to be changed, either because a previous vitrectomy used the sites that you would have chosen, or because of a glaucoma operation. For example, a trabeculectomy at noon will encourage to place the infusion at 1:30. Okay, you made your choices of illumination and visualization. You have chosen the size and the location of your trocar. You now have to make choices about vitrectomy. These choices are difficult to make because they involve many different things, such as your desire to remove more or less vitreous, your vitrectomy machine, the parameters you will use, your personal statistics on your complications, your conception of medicine, and even your temperament. That's why we're going to stop here a little bit. Let's first see how much vitreous you will want to remove. Not easy to answer. We have seen in the previous chapters that in edema, as in epithelial membranes, the vitreous is not sick. In edema, it has nothing to do with the disease. In membranes, it is certainly involved, but only because it is attached to the retina when the ischemia occurs, but it is not sick. There would therefore be no reason in itself to remove it. Some, like Shimizu, even tried to do without vitrectomy, but they stopped because the vitreous bothered them in these precise manipulation. We must therefore remove at least the posterior vitreous to be able to work. But the question is, should only a posterior vitrectomy or a more complete vitrectomy be done? My answer is, it all depends on your respective complication rates. I can hear the young surgeons starting their practice and telling me, yes, but to compare our own statistic, we need at least 300 procedures for each technique. What to do when we start? So I'm not going to run away. We have to talk about the respective complications, and I will tell you why I chose to do only a posterior vitrectomy. Regarding the rate of endophthalmitis, I have never seen or heard anyone having a difference in incidence depending on whether it is a total or partial vitrectomy, so it's not going to play in the debate. With regard to the cataract rate, I really think that a vitrectomy limited to the posterior pole leads to less cataract than a total or subtotal vitrectomy. If I compare the figures usually announced in case of total vitrectomy with this statistic that Mariano Hiros had done on a series of 2,400 macular surgeries, successive macular surgeries that I have done in the 90s, where only half of the phakic patients had been operated for cataract surgery after 4 years. Is it because the vitreous matrix left in contact with the lens delays its accelerated aging? Is it because a total vitrectomy exposes more to crystalline touch? Is it because of my technique with the slit lamp and the two sclerotomies placed close one to the other, which avoids crystalline lesions? Is it because I've always worked with a flow control machine and avoided working with a high cutting frequency? I don't know. Whatever the reason, I'm convinced that partial vitrectomy is less complicated by cataract. That said, cataract is not a disaster in itself, and it is not this complication that will prevail in your choice. The retinal detachment rate is much more important to discuss. First of all, it must be accepted that any ocular trauma, either by its mechanical action or by its inflammatory repercussions, will affect the vitreous statics and may therefore increase the rate of spontaneous regmatogenous retinal detachment due to the simple PVD, which is order of 0.3 to 0.4%. This rate rises to 1% in case of uncomplicated phaco and to more than 3% in case of YAG capsulotomy, to give an average rate after cataract of around 2%. I had presented in 2000 an interesting statistic on macular holes where my detachment rate went from 2% in stage 4 to 4% in stages 2 and 3. Until that date, in these stages 2 and 3 where the PVD is not constituted, I was used to force the PVD to the equator, and this is probably what explains this difference in rate. It is therefore clear that the more traumatized the eyelid, the higher the RD rate increases. Klaus Luker, who was not only an excellent surgeon but very honest about his complications, used to say that in his systematic peripheral vitrectomies, removal of the hyoid to the vitreous base resulted in an average of 10% iatrogenic tear, which is absolutely consistent with this statistic. To conclude this chapter on the problem of whether to perform a complete vitrectomy or limited to the posterior pole, I will therefore say, first of all, avoid performing a subtotal vitrectomy, leaving just in place a small ring of peripheral vitreous, because in this case the smallest incarceration in the sclerotomy can be transformed into a traction on the vitreous base and therefore into a tear. You can do a total vitrectomy, but then it must be really total, at the risk of creating iatrogenic tears that you will treat intraoperatively, as did Klaus Lucke. Personally, my rate of 2% RD after 4 years follow-up, identical to the one after phaco, reinforced me in the idea that performing only a posterior vitrectomy without pulling on the hyoid beyond the arcade, leaving the PVD to constitute at its own rhythm, was far from being absurd. If incarceration in a sclerotomy occurs, its action will be lost in the vitreous magma and will have no impact on the vitreous base. This also explains why I never checked the periphery at the end of membrane surgery, just as we do not check at the end of cataract surgery. Well, now that we know what we want to do, let's see how we will do it. That is to say, what are the choices that will allow us to reduce our complications. Let's set up quickly to start choosing the vitrectomy machine. If you begin your surgical career, don't bother with a machine equipped with a venturi pump. Whenever it is a question of aspirating fluids of different viscosities, this type of pump is never chosen either in other surgical specialties or in other industrial domains, precisely because this type of pump does not allow to control the flow of aspirated fluids. You have seen in the chapter of the result that in vitrectomies for floaters, which strongly look like vitrectomies for edema, the multivariate analysis identified the use of a venturi pump as a statistically significant variable responsible for more postoperative retinal detachment and more postoperative cataracts. So listen only to the surgical interest for your patients and choose machine with an aspiration flow control pump. Now let's see what are the parameters you will use. You have an aspiration flow control pump, which means that you have a foot pedal with simultaneous and independent control of aspiration flow and cutting frequency. You first must set up the extremes you don't want to exceed. For depression, commonly called vacuum, put the maximum possible, minus 600 and minus 650 millimeters of the mercury, depending on your machine. This maximum of vacuum corresponds to the maximum of your car rev counter. As soon as you control your speed, you would not think of restricting the possibility of getting into your car's engine revolutions, because you may need this power reserve to overtake a truck or climb a hill. Here it is the same. Keep intact this reserve of power. It is not dangerous since you control your flow. However, adjust your maximum aspiration flow. It must not exceed your maximum infusion rate to avoid creating hypotonia. And this implies that you must know your maximum infusion capacity. It will depend on the tubing that you will use, 23, 25 or 27 gauge, the connection to the plug, high flow or not, and the infusion pressure. Also, determine the maximum cutting frequency you want at the end of your pedal movement, knowing that the faster you cut, the less vitreous you catch. Personally, I had control of the aspiration flow by pressing the pedal vertically and the cutting frequency by moving my pedal horizontally on the right, and I chose a maximum of 1000 cuts per minute. From there, you will control at each moment at the pedal, independently and simultaneously, the aspiration flow and the cutting frequency. The vitreous is a non-Newtonian fluid. That is to say that because of its cohesion, it has a certain inertia to move. It will be dragged into the probe's door by the flow of infusion liquid, which moves instantly. That implies that as your aspiration flow increases and your cutting frequency decreases, you will be more efficient but more dangerous. Indeed, between two cuts, the vitreous will have time to enter the door of the vitrectomy handpiece and to exert remote traction. On the other hand, the lower your flow rate and the higher the cutting frequency, the more inefficient you will be. Beyond 4,000 or 5,000 cuts per minute, you will not leave enough time to the vitreous to move between two cuts, and you will aspirate only the infusion liquid in contact with your vitrectomy probe. So you see that, again, it's all a question of benefit-risk ratio. That said, when you start your vitrectomy at a long distance from the vitreous base, you have little risk of causing traction, so you can simply look for efficiency by choosing, as I did, a 10 cc per minute aspiration rate and a cutting frequency between 800 and 1000. Only when approaching the periphery you will need to reduce your flow rate. I will explain how I performed a very accurate and complete peripheral vitrectomy safely when I tell you about retinal detachment. For now, since I was doing only a posterior vitrectomy, here are my tips and tricks. First of all, adjust the sound signal of the aspiration so that it varies according to the vacuum level and not according to the flow rate. The flow rate, you know it, since it depends only on the position of your foot on the pedal. But the vacuum required to obtain the flow you have chosen, you don't know it. It depends on the viscosity of the fluid in which you are located. When, after heating the vitreous, you are in the infusion liquid, the change in sound will tell you. It's like the machine talking to you and telling you where the vitrectomy probe is placed. To make those who are not used to this trick understand. Here is a recording I made for a vitreous hemorrhage. I start the vitrectomy. My maximum vacuum is at minus 600 millimeters of mercury. My max flow rate is 14 cc's per minute, but I use around 12 cc's only, and I cut at 800 cuts per minute. I am in the vitreous, so the sound is quite high, because the vacuum required to obtain these 12 cc's is high, between minus 400 and minus 500 millimeters of mercury. Then you see, suddenly, without me changing my flow rate, the sound starts to get lower because the vacuum drops spontaneously to minus 70 millimeters of mercury. There is no more vitreous around my handpiece, and the machine tells me, Didier, you finished the vitrectomy of the posterior pole. So here, what I suggest to you: insert your probe directly to the macula, up to 3 or 4 millimeters, and press the flow control pedal fully to suck, for example, at 10 cc's per minute, cutting at 800 cuts per minute. Sometimes it is obvious that the PVD is already formed because you see the prepapillary ring moving. So you stay there quietly by moving slightly while remaining in the middle of the vascular arcade until the sound of the vacuum signals that you have removed the posterior vitreous. It will have taken you less than a minute. You can then stop and remove your probe. Sometime you will see the retina of the posterior pole beat while you cut, but be careful, you will not see this phenomenon if you cut faster. This means that there were no PVDs, so you have to do it. And I propose you the following technique. Continue to hit the vitreous in front of the posterior pole, but never approach the retina within 4 millimeters. After a short while, the sound of the vacuum will tell you that you are in the effusion liquid, and therefore you have created a large gap in front of a 4 millimeter thick vitreous mattress. At this point, continue to aspirate but stop cutting and approach the retina near the optic nerve. The fibers of the vitreous mattress will engage in the probe door, clog the door, and the sound of the vacuum will tell you that you are in occlusion. You can then easily create the PVT by pulling the vitreous master into the central gap you created, and then you will hit that mattress. Be careful not to pull this mattress too far away so as not to detach the posterior haloid to the equator, so as not to reproduce the error I made in the stage 2 and 3 macular holes until the year 2000. Finally, know that if at any time hypotonia occurs, stop immediately the aspiration. There may be two reasons for this. Either your infusion cannula has bent and the liquid is no longer flowing, or your plug is located under the pigment epithelium and must be replaced. There, your posterior vitrectomy is finished. You will move on to the staining of the tissues to be removed, which we will see in the next chapter.